Section. Introduction. We're going to delve into the importance of the conversation between a doctor and their patient. This interaction is crucial for providing effective and compassionate healthcare. In fact, it's often said that the medical interview is the most powerful tool a doctor has. In many cases, up to 80% of diagnoses are made just by talking to the patient and understanding their medical history. But the conversation goes beyond just diagnosing the patient. It's also about building trust, addressing health needs, and empowering patients to make informed decisions about their care. However, access to this level of expertise is not always available, especially on a global scale. This is where recent advancements in artificial intelligence, AI, come into play. Large language models, LLMs, a type of AI, have shown promise in planning, reasoning, and holding natural conversations. This opens up the possibility of developing AI systems that can understand clinical language, gather information intelligently, and engage in meaningful medical conversations with patients and their caregivers. The potential benefits of such AI systems are vast. They could improve access to diagnostic expertise, enhance the quality and consistency of care, and make healthcare more affordable. This could lead to better health outcomes, especially for those facing healthcare disparities. However, while these AI systems have shown promise in answering medical questions accurately, their conversational abilities have not been fully explored in the context of clinical medicine. The process of taking a patient's medical history and engaging in diagnostic dialogue is complex and highly dependent on context. Therefore, it's important to evaluate these AI systems on multiple fronts, including the structure and completeness of the history they gather, their diagnostic accuracy, the appropriateness of their management plans, and their ability to build relationships and communicate effectively with patients. In this study, we're going to share our progress in developing a conversational medical AI system for clinical history taking and diagnostic reasoning. We've named this system AMIE, which stands for Articulate Medical Intelligence Explorer. AMIE is designed to work across various specialties and scenarios. We've developed a unique self-play-based simulated diagnostic dialogue environment to help AMIE learn more quickly and effectively. We've also introduced a strategy to improve AMIE's diagnostic accuracy and conversation quality. To evaluate AMIE, we've developed a pilot evaluation rubric that assesses history taking, diagnostic reasoning, communication skills, and empathy. We've tested AMIE in a study with 149 case scenarios from clinical providers in Canada, the UK, and India. The results showed that AMIE had superior diagnostic accuracy compared to primary care physicians, PCPs, in many areas. In fact, AMIE was rated superior to PCPs in 28 out of 32 evaluation areas from the specialist physician perspective and 24 out of 26 areas from the patient-actor perspective. However, our research has limitations. For instance, we used a text chat interface, which is not a familiar format for remote consultation for many PCPs. Therefore, our study may not fully represent usual practice in telemedicine. Despite these limitations, we believe our research is a significant step towards the real-world clinical application of AI systems like AMIE. Section Summary. The physician-patient dialogue is crucial for effective healthcare, and recent advancements in artificial intelligence, AI, have the potential to revolutionize medical conversations. However, while AI models have shown promise in single-turn question answering, their conversational capabilities in clinical medicine are still limited. In this study, we introduce AMIE, an AI system optimized for clinical history taking and diagnostic dialogue, and evaluate its performance against primary care physicians, PCPs, in a simulated diagnostic dialogue environment. AMIE demonstrated superior diagnostic accuracy and was rated higher on various evaluation metrics, highlighting its potential in improving healthcare outcomes. Section. AMIE, an LLM-based AI system for diagnostic dialogue. We're going to talk about AMIE, an AI system that we've developed to improve diagnostic conversations and clinical communication. We've used a variety of real-world data, a simulated environment, a fine-tuning process, and a chain-of-reasoning approach during inference time to optimize AMIE. AMIE was trained using a wide range of real-world data. This includes multiple-choice medical question answering, expert-curated long-form medical reasoning, electronic health record note summaries, and large-scale transcribed medical conversation interactions. In addition to generating dialogues, AMIE was also trained to answer medical questions, reason, and summarize. For medical reasoning, we used the MedQA dataset, which is made up of multiple choice questions similar to those found in the U.S. medical licensing examination. The training set had 11,450 questions, and the test set had 1,273 questions. We also used 191 MedQA questions from the training set where clinical experts provided step-by-step reasoning to reach the correct answer. For long-form medical question answering, we used a dataset that included expert-crafted long-form responses to 64 questions from Health Search QA, Live QA, and Medication QA in Multi-Med Bench. For medical summarization, we used a dataset of 65 summaries of medical notes from MIMIC-3, a large public database of intensive care unit patient records. These summaries were written by clinicians and captured key information from the original notes, while also adding new informative and clarifying phrases and sentences. For real-world dialogue, we used a dataset of 98,919 audio transcripts of medical conversations during in-person clinical visits in the United States over a 10-year period. This dataset covered 51 medical specialties and 168 medical conditions and visit reasons. The conversations included different speaker roles such as doctors, patients, and nurses, with an average of 149.8 turns per conversation. For this study, we only used dialogues involving doctors and patients. We removed nonverbal annotations like laughing and inaudible from the transcripts and divided the dataset into training, 90%, and validation, 10%, sets. While collecting and transcribing real-world dialogues is possible, it has limitations. The existing real-world data often doesn't cover all medical conditions and scenarios, and the data can be noisy, containing ambiguous language, interruptions, ungrammatical utterances, and implicit references. To overcome these limitations, we created a simulated learning environment for diagnostic medical dialogues. We used this environment to continuously fine-tune AMIE with an evolving set of simulated dialogues, in addition to the static corpus of medical QA, reasoning, summarization, and real-world dialogue data. This process involved two self-play loops, an inner loop where AMIE refined its behavior on simulated conversations with an AI patient agent using in-context critic feedback, and an outer loop where the refined simulated dialogues were incorporated into subsequent fine-tuning iterations. This created a continuous learning cycle. Section Summary. In this section, the authors describe the datasets and environments used to optimize AMIE, an AI system for diagnostic dialogue. They utilized real-world datasets including medical question answering, expert-curated medical reasoning, electronic health record note summaries, and transcribed medical conversation interactions. Additionally, they designed a simulated self-play environment to address the limitations of real-world data and iteratively fine-tuned AMIE using simulated dialogues. Section: Simulated Dialogues. We fine-tuned our model through a series of simulated dialogues. In each round of fine-tuning, we generated 11,686 dialogues, which were based on 5,230 unique medical conditions. These conditions were chosen from three different datasets: the Health QA dataset, which included 613 common medical conditions, the Mollicard's Human Disease Database, which listed 18,455 less common diseases, and the MedicineNet Diseases and Conditions Index, which contained 4,617 less common conditions. For each round of self-play, we created 4 dialogues for each of the 613 common conditions and 2 dialogues for each of the 4,617 less common conditions, randomly selected from the MedicineNet and Mollicard's databases. The average length of these simulated dialogues was about 21.28 turns, with the 25th percentile at 19 turns and the 75th percentile at 25 turns. These simulated dialogues helped us overcome the scarcity of high-quality, labeled real-world conversation data, and enhanced the model's ability to adapt to a variety of medical contexts. By using this self-play approach, our model, AMIE, could continually learn and improve its conversational and diagnostic skills during patient interactions. To generate high-quality simulated dialogues on a large scale, we developed a unique multi-agent framework. This framework consisted of 3 main components: a vignette generator, a simulated dialogue generator, and a self-play critic. AMIE played all roles in this framework. The vignette generator was designed to create diverse and realistic patient scenarios, which could then be used as context for generating simulated doctor-patient dialogues. This allowed AMIE to undergo a training process that mimicked exposure to a wide range of conditions and patient backgrounds. The patient scenario included important background information such as patient demographics, symptoms, past medical history, past surgical history, past social history, and patient questions, as well as an associated diagnosis and management plan. To create a patient scenario for a given condition, we first retrieved 60 passages, 20 each, on the range of demographics, symptoms, and management plans associated with the condition from an internet search engine. We used the General-Purpose Language Model, PALM2, to filter these retrieved passages, removing any passages that were not related to the given condition. We then prompted AMIE to generate plausible patient scenarios that aligned with the demographics, symptoms, and management plans retrieved from the filtered passages. The simulated dialogue generator was designed to simulate a realistic dialogue between a patient and a doctor in an online chat setting, where in-person physical examination may not be possible. 3 specific language model agents, patient agent, doctor agent, and moderator, all played by AMIE, were tasked with communicating amongst each other to generate the simulated dialogues. Each agent had distinct instructions. The patient agent embodied the individual experiencing the medical condition outlined in the scenario. Their role involved truthfully responding to the doctor agent's inquiries as well as raising any additional questions or concerns they may have had. The doctor agent played the role of an empathetic clinician seeking to understand the patient's medical history within the online chat environment. Their goal was to formulate questions that could effectively reveal the patient's symptoms and background, leading to an accurate diagnosis and an effective treatment plan. The moderator continually assessed the ongoing dialogue between the patient agent and doctor agent, determining when the conversation had reached a natural conclusion. The dialogue simulation started with the doctor agent initiating the conversation. "Doctor, so, how can I help you today?" Following this, the patient agent responded, and their answer was incorporated into the ongoing dialogue history. Subsequently, the doctor agent formulated a response based on the updated dialogue history. This response was then appended to the conversation history. The conversation progressed until the moderator detected the dialogue had reached a natural conclusion, when the doctor agent had provided a differential diagnosis, treatment plan, and adequately addressed any remaining patient-agent questions, or if either agent initiated a farewell. Section Summary. The authors generated 11,686 simulated dialogues from 5,230 different medical conditions, using a multi-agent framework. They developed a vignette generator to create realistic patient scenarios and a simulated dialogue generator with 3 agents, patient, doctor, and moderator, to simulate diagnostic interactions. By leveraging this self-play paradigm, their model, AMIE, continuously learned and improved its conversational and diagnostic capabilities in diverse medical contexts. Section. Self-play critic. We've developed a unique self-play framework to improve the quality of diagnostic conversations. This framework includes a 4th agent, known as the critic, which is also controlled by our AI system, AMIE. The critic, who knows the correct diagnosis, provides feedback to the doctor agent to help it improve its performance in future conversations. The critic evaluates the doctor agent's responses based on several criteria. First, the doctor agent should show empathy and professionalism while responding to the patient agent's latest questions or comments in a clear and concise way. Second, the doctor agent should avoid asking too many or repetitive questions, focusing on a maximum of 1 or 2 per response. Third, the responses should not reveal that the doctor agent is an AI chatbot. They should seem natural, be factually accurate, and encourage further engagement from the patient. Lastly, the doctor agent should ask enough questions to identify at least 2 of the most likely differential diagnoses. They should then refine their understanding through targeted questions towards the correct diagnosis and suggest the appropriate treatment. After receiving feedback from the critic, the doctor agent uses these suggestions to improve its responses in future rounds of dialogue with the same patient agent. Importantly, the doctor agent can refer to its previous dialogue history in each new round. This self-improvement process is repeated twice to generate the dialogues used for each round of fine-tuning. AMIE, which is built on the base language model PALM2, was fine-tuned to enhance its capabilities for medical dialogue and reasoning. We used task-specific instructions to fine-tune AMIE in playing either the patient or doctor role within medical dialogues, answering medical questions, reasoning, and summarizing electronic health record (EHR) notes. For dialogue generation tasks, AMIE was trained to predict the next conversational turn based on all previous interactions, assuming either the doctor or patient role. When playing the patient agent, AMIE was prompted to reply to the doctor agent's questions about their symptoms, using information provided in patient scenarios. In the doctor agent role, AMIE was prompted to act as an empathetic clinician, interviewing patients about their medical history and symptoms to ultimately arrive at an accurate diagnosis. To address the challenge of acquiring information under uncertainty to enhance diagnostic accuracy and confidence while maintaining a positive rapport with the patient, AMIE uses a chain of reasoning strategy before generating a response in each dialogue turn. This strategy involves a series of sequential model calls, each dependent on the outputs of prior steps. First, AMIE analyzes the patient information given the current conversation history. It summarizes the patient's symptoms and any relevant medical, family, or social history and demographic information. It then produces a current differential diagnosis, notes missing information needed for a more accurate diagnosis, and assesses confidence in the current differential and its urgency. Next, AMIE formulates a response and action based on the conversation history and the output of the first step. It generates a response to the patient's last message and formulates further questions to acquire missing information and refine the differential diagnosis. If necessary, it recommends immediate action, such as an emergency room visit. If confident in the diagnosis based on available information, it presents the differential. Finally, AMIE refines its response to meet specific criteria based on the conversation history and outputs from earlier steps. The criteria are primarily related to the factuality and formatting of the response. This chain of reasoning strategy enables AMIE to progressively refine its response based on the current conversation to arrive at an informed and grounded reply. Section Summary. In order to improve the quality of diagnostic conversations, we implemented a self-play framework that involved a critic agent providing feedback to the doctor agent based on criteria such as empathy, professionalism, concise responses, and natural flow. The doctor agent incorporated this feedback to enhance its performance in subsequent conversations. Additionally, AMIE was instruction fine-tuned using task-specific instructions and simulated dialogues generated through self-play to enhance its capabilities for medical dialogue and reasoning. Finally, AMIE employed a chain of reasoning strategy, involving sequential model calls, to effectively acquire information, enhance diagnostic accuracy, and maintain positive rapport with the patient. Section. Evaluation. In previous research, models for clinical dialogue have been evaluated based on metrics such as the accuracy of note-to-dialogue or dialogue-to-note generations, or natural language generation metrics like Blue or Rouge scores. However, these metrics don't necessarily reflect the clinical quality of a consultation. In contrast, we decided to base our human evaluation on criteria more commonly used for assessing the quality of physicians' expertise in history taking, including their communication skills in consultation. We developed a framework based on principles published in reviews of the Consensus for Best Practices for Patient-Centered Communication in Medical Interviews, criteria examined for history-taking skills by the Royal College of Physicians in the UK, and criteria proposed by the UK General Medical Council Patient Questionnaire for doctors seeking patient feedback. We refined these criteria and created pilot scales and instructions for assessment. We used focus groups and interviews with clinicians and examiners from the UK, Canada, US, and India to help us in this process. Our pilot framework allowed for assessment from two perspectives, clinician and lay raters. The framework considered consultation quality, structure and completeness, and the roles, responsibilities, and skills of the interviewer. The Objective Structured Clinical Examination, OSCE, is a practical assessment format used in healthcare to assess clinical skills and competencies in a standardized and objective way. It differs from traditional written or oral exams that focus primarily on theoretical knowledge. Instead, it aims to provide an environment in which the skills of real-world clinical practice can be assessed. The OSCE is typically divided into multiple stations, each simulating a real-life clinical scenario. At each station, students are given specific tasks to perform, such as taking a clinical history or making a diagnosis. Trained examiners observe students' performance at each station using a predefined checklist or marking scheme. They assess clinical skills like communication, history-taking, physical examination techniques, clinical reasoning, and decision-making. To compare the performance of our model, AMIE, to that of real clinicians, we conducted a study in the style of a remote OSCE. Our study involved 20 board-certified primary care physicians and 20 validated patient actors from India and Canada. We used 149 scenario packs from India, Canada, and the UK. Each scenario pack was associated with a ground truth diagnosis and a set of acceptable diagnoses. The scenario packs covered conditions from various medical domains. Pediatric or psychiatry domains were excluded from this study, as were intensive care or inpatient case management scenarios. For the experiment, each simulated patient completed 2 online text-based consultations via text chat interface, one with a primary care physician and one with AMIE. The order of the consultations was randomized and patient actors were not informed as to which they were talking to in each consultation. Both the primary care physicians and AMIE were asked to not reveal their identity, or whether they were human, under any circumstances. Section Summary. In this section, the authors discuss the evaluation of their clinical dialogue model. They explain that previous works focused on metrics like accuracy or language generation scores, which failed to capture the clinical quality of a consultation. Instead, the authors developed a framework based on best practices for patient-centered communication and criteria used for assessing history-taking skills in medical interviews. They conducted a remote objective structured clinical examination, OSCE, study involving board-certified physicians and patient actors to compare their model's performance to that of real clinicians. Section. Post-questionnaires. After the consultation, both the patient actor and the OSCE agent filled out a post-consultation questionnaire based on the transcript of the consultation. The patient actor's questionnaire included the full GMCPQ, parts of the PACEs related to managing patient concerns and maintaining patient welfare, and a checklist for the PCCBP category of fostering the relationship. The responses given by the patient actors are referred to as patient actor ratings. The OSCE agent's questionnaire asked for a ranked list of potential diagnoses, with a minimum of 3 and a maximum of 10, as well as recommendations for further consultation, investigations, treatments, management plans, and follow-up. Next, a group of 23 specialist doctors from India, North America, and the UK evaluated the quality of the consultation and the responses to the post-consultation questionnaire. These specialists had access to the full scenario pack and its associated differential diagnoses. The specialists were chosen to match the specialties and geographic regions of the scenario packs used in our study, and had between 1 and 36 years of experience after their residency. Each set of data was evaluated by one specialist, who was randomly assigned to match the specialty and geographic region of the scenario. The same specialist evaluated the data from both the PCP and AMIE for a given scenario. The evaluation criteria included the accuracy, appropriateness, and comprehensiveness of the provided list of potential diagnoses, the appropriateness of recommendations for further consultation, investigation, treatment, management plan, and follow-up, and all PACEs and PCCBP rating items. In addition to human evaluations, we also used model-based auto-evaluation methods as cost-effective and consistent alternatives to specialist assessments. These methods were used to evaluate both the quality of the dialogue and the accuracy of the diagnosis. To validate our auto-evaluation methods for assessing dialogue quality, we initially focused on 4 evaluation axes from the PACEs rubric that were assessed by both the patient actors and the specialist physicians. The auto-evaluation, which uses a self-caught strategy with AMIE to rate dialogues, was in good alignment with human raters and comparable to the agreement between specialists on these criteria. For the auto-evaluation of potential diagnoses, we used another LLM, MedPalm2, as a surrogate for a specialist rater to grade the predicted diagnoses against the actual diagnoses. Our auto-evaluation on the accuracy of the potential diagnoses showed a similar trend for AMIE and OSCE agents compared to the specialist ratings. Overall, auto-evaluation trends aligned with human ratings for both dialogue quality and diagnostic accuracy. We also conducted additional auto-evaluation analyses to compare the accuracy of the potential diagnoses derived from AMIE or PCP consultations, to compare the accuracy of the potential diagnoses between simulated patients in Canada and India, to analyze the accuracy of AMIE's potential diagnoses when provided the PCP consultation instead of its own, to evaluate the efficiency of information acquisition between AMIE and PCPs, and to evaluate the benefit of inner-loop self-play on dialogue quality before and after critic feedback. We evaluated the top K accuracy of the potential diagnoses lists generated by AMIE and PCPs across all 149 simulated patients. Top K accuracy was defined as the percentage of cases where the correct diagnosis appeared within the top K positions of the potential diagnoses list. A candidate diagnosis was considered a match if the specialist rater marked it as either an exact match with, very close to, or closely related to the actual diagnosis. Statistical significance for potential diagnoses accuracy was determined using bootstrap tests with 10,000 samples and false discovery rate correction across all K. Statistical significance for patient actor and specialist ratings was determined using Wilcoxon signed rank tests with FDR correction. Cases where either agent received, cannot rate, does not apply, were excluded from the test. The results below refer to p-values after FDR correction. Section Summary. In this section, post-questionnaires were filled out by patient actors and OSCE agents after the consultation. The patient actors questionnaire included ratings on various aspects of the consultation, while the OSCE agents questionnaire asked for a ranked list of differential diagnoses and recommendations. Specialist physicians evaluated the consultations and questionnaire responses, considering factors such as accuracy, appropriateness, and comprehensiveness. Additionally, model-based auto-evaluation methods were used to assess dialogue quality and diagnostic accuracy, which aligned well with human ratings. Statistical analysis was conducted to evaluate the accuracy of the differential diagnoses generated by both the OSCE agent and PCPs. Section. Results. Our findings indicate that AMIE, our artificial intelligence model, demonstrated a higher level of diagnostic accuracy compared to primary care physicians, PCPs, when evaluated by specialist physicians. In a comparison of top K accuracy, which measures the likelihood of the correct diagnosis appearing in the top K predictions, AMIE consistently outperformed PCPs. This was true even when the criteria for a match varied. It's important to note that PCPs didn't always provide 10 diagnoses in their differential diagnoses, with the minimum being 3 and the average being around 5.39. When we looked at the diagnostic accuracy across 6 medical specialties, AMIE either matched or surpassed the performance of PCPs in all areas. The most significant improvements were seen in the respiratory and cardiovascular specialties. We also used an auto-evaluator, a model-based tool, to assess the diagnostic accuracy. The results were largely in line with the specialist assessments, despite minor differences in the calculated accuracy values. To understand why AMIE performed better, we compared diagnoses made by AMIE based on its own consultations with those made from PCP consultations. The results showed that AMIE's diagnostic performance was consistent, regardless of whether it processed information from its own dialogue or from the PCP's conversation. This suggests that while AMIE and PCPs were equally good at gathering information, AMIE was better at interpreting that information to produce an accurate diagnosis. In terms of information acquisition, AMIE and PCPs were similar. Both had comparable numbers of conversational turns and elicited a similar number of words from the patient actors. When we truncated the conversations at various turn counts and used AMIE to generate diagnoses based on these partial conversations, we found that both AMIE and PCPs were able to gather the necessary information for a diagnosis within the first 10 conversational turns. In terms of conversation quality, AMIE outperformed PCPs according to both specialists and patient actors. Patient actors rated AMIE's consultations significantly better than those from PCPs across 24 of 26 criteria. The only 2 areas where there was no significant difference were respecting patients' privacy and acknowledging mistakes. Specialist physicians also rated AMIE's consultations, diagnoses, and management plans higher than those from PCPs on 28 of 32 evaluation criteria. There were no significant differences in ratings for 4 of the criteria in the diagnosis and management rubric, namely, escalation recommendation appropriate, treatment inappropriate avoided, follow-up recommendation appropriate, and confabulation absent. Section Summary. The I model AMIE demonstrated higher accuracy in generating differential diagnoses, DDX, compared to primary care physicians, PCPs, when evaluated by specialist physicians. AMIE consistently outperformed PCPs across various matching criteria and medical specialties, particularly in respiratory and cardiovascular cases. The superior performance of AMIE was attributed to its ability to interpret information and produce accurate and complete DDX, regardless of whether the information was acquired from its own dialogue or from the PCP's conversation. Both AMIE and PCPs were equally efficient in acquiring information from patients, as indicated by similar conversation lengths and turn counts. Patient actors and specialist physicians rated AMIE's consultations significantly better than those of PCPs in terms of conversation quality. Section: Auto-evaluation of conversation ratings. We used a self-evaluation strategy based on our model, called self-COT, to assess conversations. This strategy evaluated the conversations based on 4 criteria from the PACES rubric. We found that these self-evaluations were accurate and matched well with evaluations done by experts. We also used this self-evaluation method to assess simulated dialogues before and after they underwent a self-play process. The results showed that the dialogues improved after self-play, and were preferred over the original dialogues that didn't go through self-play. In medical education, both at the undergraduate and postgraduate levels, history-taking and clinical interviews are key components. Over time, the consensus on doctor-patient communication has shifted towards patient-centered practices. It's recommended that such communication should fulfill 6 main functions: building the relationship, collecting and providing information, decision-making, responding to emotions, and facilitating disease and treatment-related behavior. Specific skills and behaviors to achieve these goals have been identified, taught, and evaluated using validated tools. It's generally agreed that certain types of information should be collected during a clinical interview, such as the patient's main complaint, past medical history, medication history, social and family history, and a review of systems. The ability of clinicians to meet these goals is often assessed using an objective structured clinical examination, OSCE. These assessments can vary in their reproducibility and implementation, and have even been adapted for remote practice as virtual OSCEs, VOCEs, which has been particularly relevant during the COVID-19 pandemic. Conversational AI systems designed for goal-oriented dialogue and task completion have a long history. The advent of transformers and large language models has sparked renewed interest in this area. The development of strategies for alignment, self-improvement, and scalable oversight mechanisms have allowed these conversational systems to be deployed on a large scale in the real world. However, the thorough evaluation and exploration of the conversational and task completion capabilities of these AI systems in clinical applications remain limited. Most studies have focused on single-turn interaction use cases such as question answering or summarization. Most of the research on using AI for medical consultations has focused on symptom checker applications rather than full natural dialogue. Other topics include transcription of medical audio or generating plausible dialogue based on clinical notes or summaries. While language models have been trained using clinical dialogue datasets, they haven't been comprehensively evaluated. Studies have been based on messages between doctors and patients on commercial chat platforms, which may have changed doctor-patient engagement compared to one-on-one medical consultations. Many of these studies have focused mainly on predicting the next turns in the recorded exchanges rather than clinically meaningful metrics. So far, no studies have examined the quality of AI models for diagnostic dialogue using the same criteria used to examine and train human doctors in dialogue and communication skills, or evaluated AI systems in common frameworks such as the OSCE. Section Summary. The authors utilized a model-based self-COT auto-evaluation strategy to rate conversations based on the PACES rubric, and found that these auto-evaluation ratings were accurate and aligned with specialist ratings. They also applied the auto-evaluation method to simulated dialogues before and after the self-play procedure, and found that the dialogues after self-play were preferred more often than the baseline dialogues without self-critique. Additionally, previous explorations of AI in medical consultations have mainly focused on symptom checker applications or single-turn interactions, and there have been no studies evaluating the quality of AI models for diagnostic dialogue using the same criteria used to train human physicians or in common frameworks such as the OSCE. Section: Evaluation of diagnostic dialogue. In the past, the methods used to evaluate the performance of AI systems in medical dialogues have been somewhat lacking in detail. They haven't been based on established criteria for assessing communication skills and the quality of medical history taking. For instance, some studies have used a 5-point scale to describe overall human evaluation, while others have reported on relevance, informativeness and human likeness, fluency, expertise and relevance, fluency and adequacy, and simply fluency. These criteria are not as comprehensive or specific as those used by medical professionals. A multi-agent framework for assessing the conversational abilities of language models has been introduced, but the study was limited to dermatology, used AI models to simulate both doctor and patient interactions, and only evaluated history taking as complete or not. In our study, we introduced AMIE, an AI system based on a language model and optimized for clinical dialogue with diagnostic reasoning capabilities. We compared AMIE's consultations with those performed by primary care physicians, PCPs, using a randomized, double-blind crossover study with human simulated patients, similar to an objective structured clinical examination, OSCE. Our study was not designed to mimic traditional OSCE evaluations, remote medical consultation practices, or the usual ways clinicians use text and chat messaging to communicate with patients. Instead, our evaluation mirrored the most common way people interact with language models today, providing a scalable and familiar way for AI systems to engage in remote diagnostic dialogue. In this setting, we found that AMIE, which was specifically optimized for this task, performed better than PCPs in simulated diagnostic conversations when evaluated on multiple clinically relevant aspects of consultation quality. The differential diagnoses provided by AMIE were more accurate and complete than those provided by board-certified PCPs, as evaluated by specialist physicians. Previous research has shown that AI systems can match or even surpass human diagnostic performance in specific, narrow tasks, but these situations typically involve both AI and physicians interpreting the same fixed input, such as identifying a specific finding in a medical image. Our study was more challenging because it required the AI system to actively gather relevant information through conversation, rather than relying on clinical information collected by humans. Therefore, the system's differential diagnoses depended not only on its diagnostic inference capability, but also on the quality of information gathered through natural conversation and rapport building. Our results suggested that AMIE was as skilled as PCPs in eliciting relevant information during the simulated consultations and was more accurate than PCPs in formulating a complete differential diagnosis given the same amount of acquired information. This finding supports other work suggesting that language models may be able to produce more complete differential diagnoses given the same clinical information as physicians in challenging cases. Although we didn't explore this in our study, the assistive performance of AMIE represents an interesting and important area for future research, especially given the real-world importance of expert oversight for AI systems in safety-critical settings like medicine. Our study used a wide variety of simulated patients, including actors trained in both Canada and India and scenarios across a range of specialties. This allowed us to explore how performance varied by specialty and by the locations where the scenario was derived and enacted. We found that both PCPs and AMIE performed worse in obstetric, gynecology, and internal medicine scenarios than those from other specialties. The study was not designed to compare performance between different specialty topics, and we can't rule out that the scenarios in some specialties might be harder than others. We found that both AMIE and PCPs had higher diagnostic accuracy in consultations performed in the Canada OSCE lab compared to those enacted in the India OSCE lab. However, the differences were not statistically significant, and in a subset of 40 scenarios enacted in both the Canada OSCE lab and the India OSCE lab, the performance of both AMIE and PCPs was equivalent. Patient actors and specialist raters both rated AMIE's performance higher than PCPs on metrics related to empathy and communication skills. These aspects made up a majority of the dimensions that were evaluated. This general finding is consistent with a previous study where language model responses were found to be more empathetic than clinicians' responses to health questions posted on Reddit. However, the findings in that study may not be directly applicable to our setting due to differences in study design. Specifically, previous work has not involved a direct, randomized comparison of physicians and AI systems in a prospective simulation of multi-turn dialogue with the same patient. In both settings, the lack of voice-based and non-verbal visual communication may be a disadvantage to clinicians. The text-based chat interface used in this study has both advantages and disadvantages. People today most commonly interact with language models through synchronous text chat interfaces, and patients often use patient portals to send messages to their providers. We therefore chose this mode of interaction as a representative interface for language models to perform multi-turn conversation, adapting the virtual OSCE framework accordingly. While this allowed a fair comparison of diagnostic dialogue between language models and clinicians when both were restricted to a synchronous text chat, it's important to acknowledge that our experiments do not emulate the expected quality of diagnostic dialogue in real clinical practice, including telemedicine. Physicians may be more used to history-taking and diagnostic dialogue by telephone or video consultation than synchronous text chat communication. Instead, Text is more commonly used by clinicians to communicate with patients for episodic or asynchronous needs such as prescription refills or communication about specific test results. Physicians may thus be more familiar with text, SMS, or email rather than the synchronous text chat medium we used in this study. In both text, SMS, and email, the conventions and expectations for communicating naturally and with empathic style might be different. It's possible that the PCPs in our study were not yet accustomed to the setting, and may have performed differently if subjected to a specific training program, similar to the training process for AMIE. Clinicians participating in the study undertook 2 preparatory pilot sessions of consultations with our synchronous text interface before the evaluation began, but this was not a formal training program, nor was it designed to optimize clinicians' performance. Future research could explore this question more thoroughly, including monitoring for the impact of a learning curve, or exploring whether performance varies according to the extent to which participating clinicians or simulated patients are familiar with telemedicine. Additionally, our findings regarding empathic communication could also be partially attributed to the fact that AMIE responses were significantly longer than clinician responses and presented with greater structure. This could potentially suggest to an observer that more time was spent preparing the response, similar to known findings that patient satisfaction increases with time spent with their physicians. Collectively, our findings suggest many avenues for further research that might leverage the complementary strengths of humans and AI, combining clinicians' skills in the analysis of verbal and non-verbal cues with the potential strengths of language models to suggest more enriched conversational responses, including empathic statements, structure, eloquence, or more complete differential diagnoses. Section Summary. The evaluation of diagnostic dialogue in previous frameworks for assessing AI systems' performance has been limited and not aligned with established criteria used by medical professionals. However, a study introduced AMIE, an AI system optimized for clinical dialogue, and found that it outperformed primary care physicians in simulated diagnostic conversations, providing more accurate and complete differential diagnoses. AMIE also received higher ratings for empathy and communication skills compared to physicians, suggesting potential for human-AI complementarity in diagnostic dialogue. Section: Simulated Dialogue. We used simulated data to quickly expand our training across a variety of conditions and patient contexts. This approach, combined with insights from search, helped us create realistic dialogues. However, our simulated patients didn't fully represent the diversity of patient backgrounds, personalities, and motivations. We used a process called inner self-play to gradually improve the simulated dialogues we created. But our progress was limited by our ability to define what makes a good dialogue, the feedback we received, and our AI system, AMIE's, ability to adapt to this feedback. For instance, we required AMIE to propose a diagnosis and treatment plan for each simulated patient, but this might not be realistic for all conditions, especially in a virtual chat setting. In terms of evaluation, we used established criteria for assessing doctors' communication skills and history-taking quality, unlike previous studies. We conducted a more comprehensive and diverse human evaluation, with ratings from both clinicians and simulated patients. Our raters and scenarios came from various locations, including North America, India, and the UK. We believe our evaluation rubric is the first to assess AI systems' history-taking and communication skills using criteria also used for real-world doctors, making our research more clinically relevant. However, our evaluation framework can be improved further. What makes a good history depends on many factors, including the specific clinical situation, patient and doctor attributes, cultural characteristics, and more. Future studies could use real-world measures of outcomes like patient complaints, cost and care effectiveness, and patient and provider satisfaction. Our evaluation criteria were not exhaustive and their interpretation was often subjective. While we conducted evaluations from both clinician and lay perspectives, we could expand the pool of evaluators to improve the generalizability of our findings. Our experiments could also be replicated more extensively to explore other aspects such as variability between observers and participants. We could also involve a more diverse group of human raters in the design of our evaluation tools. Although our scenarios covered many different clinical conditions and specialties, they didn't represent the vast range of conditions a single doctor might encounter in their career. We didn't design our experiments to examine multiple diseases at once, long-term case presentation, or the use of sequential information from clinical investigations. We also didn't include some clinical settings or specialties like psychiatry, pediatrics, intensive care, and inpatient case management. Further research is needed to understand how our findings apply to these settings, where the requirements for high-quality history taking might differ. We used a framework called the Objective Structured Clinical Examination, OSCE, to assess clinicians' skills. This approach has many methods, including real or simulated patients, interaction with physical artifacts or clinical materials, applications to various medical specialties, tasks or settings, and both remote or in-person assessments. However, the OSCE approach has significant limitations. We used a remote text-based assessment, which has known issues like the inability to include non-verbal symptoms, signs, and communication features. This format could also introduce unfamiliar constraints to the communication of primary care providers. The dialogues in our study may not accurately represent real-world patient populations. For example, patient actors may have described their symptoms with more structure, depth, or clinical detail than typical patients. They may also have understood the clinical context better than most patients. Additionally, although our evaluation was blinded, AMIE's responses were noticeably different from those of primary care providers, which limits the practical extent of blinding in our study design. Therefore, our findings should be interpreted with caution. Further research is needed to examine varied presentations of the same diseases and explore alternative approaches to evaluating history taking and clinical dialogue in situations with different patient needs, preferences, behaviors, and circumstances. Section Summary. The use of simulated data allowed us to train our model in various conditions and patient contexts, but it failed to capture the full range of patient backgrounds and motivations. Our evaluation framework, which included ratings from clinicians and simulated patients, was based on established criteria for assessing physicians' communication skills, making our research clinically relevant. However, our evaluation framework can still be improved, and future studies should consider real-world outcomes and involve a more diverse pool of assessors. Section: Fairness and Bias. Our paper's evaluation protocol has its limitations, especially when it comes to identifying issues related to fairness and bias. This is a significant area that we plan to explore in future evaluations. Recent progress in creating comprehensive frameworks for detecting bias in large language models offers a promising foundation for this endeavor. Medical diagnostic dialogue is a complex field, making it a challenging use case. The intricacies of the medical domain, the interactive nature of the dialogue, and the outcome-driven setting all contribute to this complexity. There's also the risk of harm if a diagnosis or medical advice is incorrect. However, it's crucial to untangle these issues if we want large language models to help reduce, rather than increase, healthcare inequities. For instance, past research has shown that doctors communicate differently with patients based on their race. This has led to Black patients receiving less patient-centered communication. Other studies have found differences in doctors' communication styles and conversation length based on gender. Therefore, there's a significant risk that these historical conversational biases could be replicated or even amplified in an AI dialogue system. However, this also presents an opportunity to design more inclusive and personalized conversational systems. To develop the necessary fairness, bias, and equity frameworks, we need to involve a wide range of patient demographics, as well as clinical and health equity domain experts. These evaluation frameworks should be supplemented by extensive model red teaming and an adversarial approach to identify any remaining gaps and failure modes. The development of the model should follow established data and model reporting practices and provide transparency into the training data and the associated decision processes. The dialogue research dataset used in our study was de-identified, which reduced the availability of socioeconomic factors, patient demographics, and information about clinical settings and locations. We also need to ensure the robustness of medical large language models in multilingual settings, especially their performance in low-resource languages. The vast diversity of cultures, languages, localities, identities, and localized medical needs makes it practically impossible to create comprehensive fairness benchmarks. This research shows the potential of large language models for future use in healthcare, specifically in diagnostic dialogue. However, transitioning from a research prototype to a safe and robust tool that can be used by healthcare providers and people will require significant additional research. This includes ensuring the safety, reliability, efficacy, and privacy of the technology. We also need to consider the ethical deployment of this technology, including rigorous quality assessment across different clinical settings and research into reliable uncertainty estimation methods. These methods would allow for deferral to human clinical experts when needed. We also need to develop ways for large language models to utilize up-to-date clinical information, given the continuous evolution of clinical knowledge.